So let's take a look at each one of these problems here and talk a little bit about how this is going to present in your patient and what this is going to look like. So aspiration pneumonitis versus aspiration pneumonia. Aspiration pneumonitis is the acute thing that happens. So we're going to look for the acute mental status change in the patient that is going to be the precursor here to the patient developing aspiration pneumonitis. Now, aspiration pneumonitis is a chemical burn to the lung. It's a chemical burn that is occurring to the lung. So the patient has this one big aspiration. So look for the acute change in mental status. Maybe your patient has had an acute stroke. Maybe your patient has had an overdose, or they've had a motor vehicle accident, a change in mental status. Something has happened that's caused an acute change in mental status, which caused the patient to have the one big emesis, and they aspirated that down to the lung. Now that one big emesis causes a chemical burn to the lung, and that chemical burn is what causes aspiration pneumonitis. So some of the things that could be associated with aspiration pneumonitis include this acute change in mental status. For example, the patient has had a seizure, the patient's had a stroke. So something has happened acutely that's caused this to occur. Complications from aspiration pneumonitis include a lot of additional respiratory complications, probably one of the most severe of which being ARDS. So your patient has this chemical burn to the lung, now they're going to develop that acute lung injury, and then they develop ARDS, so that acute respiratory distress syndrome. Aspiration pneumonia, on the other hand, is caused by chronic little aspirations. So the patient has chronic little aspirations over a long period of time. Look for the chronic mental status change. So as opposed to aspiration pneumonitis, where the patient had the one big vomit, the one big aspiration, causing a chemical burn to the lung, what's happening here with aspiration pneumonia is chronic little aspirations. So the patient has a chronic change in mental status. They have a chronic change in how they're able to handle their secretions, etc. So they have some difficulty swallowing or whatever. And they're developing this over a long period of time. One of the ways that we think that our patients in the hospital develop hospital-acquired pneumonia is because the patient is having chronic little aspirations. So little micro-aspirations over a long period of time. Now that could be causing a couple things to happen. One thing could be is that we're getting chronic little chemical burns to the lung, which irritates the lung and then sets it up and makes it more apt to become infected. The second thing that could be happening is with these chronic little aspirations that maybe bacteria is living in the stomach, and that bacteria is now being aspirated up into the lungs, and that's causing our aspiration pneumonia. So we're looking for the chronic mental status change to occur in our patient. Could be a number of these different things that's causing that to happen. Now, what happens with our aspiration then is the patient is going to develop an infiltrate on their x-ray, and we're going to see an infiltrate and see symptoms, primarily dependent upon what position the patient is in. So if your patient has aspiration pneumonia because they have chronic little aspirations, if they are primarily in the semi-Fowler's position, head of the bed up 30 degrees, we're probably going to see most of those symptoms in the bases in the back. If, however, your patient was laying on their side and they had the one big aspiration, you're more likely to end up seeing symptoms in the upper lobe of whatever side the patient was laying on. Again, if the patient has that one big aspiration and has aspiration pneumonitis, we're more likely to see that aspiration occur in the right lung because the right bronchi is shorter and straighter than the left bronchi is. So more often going to happen on the right side than on the left side if the patient just has that one big aspiration. In addition, it's also going to be dependent upon the patient's position when they had that aspiration. So symptoms are going to include difficulty breathing. Your patient's going to have respiratory symptoms. We're going to see the dyspnea, the cough, possibly hypoxia, maybe sputum production, tachypnea, pleuritic type chest pain. And pleuritic chest pain is sharp, it's localized, and it's worse on inspiration. So those things we're going to see associated with this as well. Maybe some fever and chills, so signs that the patient is infected. Even if it's an aspiration pneumonitis, we still have inflammation occurring, and we may still get some of those symptoms like fever and chills and an elevated white count. Decreased breath sounds in that area because of some consolidation that's occurring in the lungs where that infiltrate occurred. Our treatment is going to be primarily that we're going to be ventilating the patient, and we're going to be monitoring the patient, maybe giving the patient some oxygen. If this was an aspiration pneumonia, the chronic little aspirations, we're also going to add some antibiotics to the mix. If it's an aspiration pneumonitis just caused by that one big aspiration, that's a chemical burn and doesn't necessarily need antibiotics. So you might see a patient who has an aspiration pneumonitis and the patient's not getting antibiotics. And the reason for that would be is because it's not a bacterial infection, it's a chemical burn, and that's why they're not being treated with antibiotics. Again, keep in mind that ARDS is a common complication of either aspiration pneumonitis or aspiration pneumonia, so keep that in mind and be watching for the development of ARDS. Remember, ARDS forms in those phases, and we have that interstitial edema phase that looks like anxiety, where we might be able to catch it early before the patient progresses in to that alveolar flooding stage, where the patient then ends up having hypoxia and that refractory hypoxemia.